Nobody other than a respiratory therapist who's trained on how to use this machine should touch anything.
Welcome back to PedScript. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are excited to be speaking to Dr. John Lin today on high-frequency percussive ventilation. Dr. Lin, will you please introduce yourself and tell us something about your clinical and academic interests related to today's topic?
Sure. So like Zach said, my name is John Lin. I am a professor of pediatrics at WashU School of Medicine in St. Louis, working at St. Louis Children's Hospital. And related to this topic, I'm the medical director for respiratory care at the Children's Hospital. And we implemented and deployed the VDR, which is the brand of ventilator that provides high-frequency percussive ventilation, in the fall of 2018. And at that time, only 3 of our critical care faculty had any hands-on clinical experience with the VDR and high-frequency percussive ventilation. None of our respiratory therapists did, and none of our nurses in the ICU had any clinical experience. But because we are a high-volume ECMO center and a lung transplant center, there was interest in adopting high-frequency percussive ventilation in our respiratory capabilities as another way for us to address patients with respiratory disease involving thick secretions and significant atelectasis. So, for instance, a cystic fibrosis patient who's waiting for a lung transplant. Our approach to VDR implementation really leveraged the interprofessional team and involved engagement and support from physician, respiratory therapy, and nursing unit leadership, and hospital administrative support. The education process included profession-specific, hands-on, and didactic education. And we also thought really carefully about which patients we would start with, and we're very, very specific about that selection for our very first few cases. When we first started it, then we provided in-person real-time support for the entire medical team at the physician and respiratory therapy level, and to the bedside clinical team from the stakeholder group that we had convened to put this together. And for the first 6 months, we did this in-person real-time support, which probably by month 5 was a little bit of overkill. But I think it really helped solidify our institution's practice in using high-frequency percussive ventilation in the VDR and has led to long-term sustained success.
Oh, absolutely. That sounds like you really built a strong foundation.
Yeah, that was our intent.
Yes. This sounds like, so you're the director of respiratory care at St. Louis Children's Hospital. This sounds like an example of how you really use that role to build up your respiratory care program. How have you approached this role overall?
So as the respiratory care medical director here at St. Louis Children's, I've really focused on the clinical and personnel development aspects of the job. And importantly to me, just the way it's set up here, the medical director role has zero responsibility from an HR perspective. So I'm not responsible for hiring, firing, discipline, any of that stuff. When the department is looking to interview managers or leaders within the department, then I'm invited to interview the applicant and I can provide my input. But the final decision is not mine, which I am thankful for. And the medical director really, in my mind, is a clinical role that is involved in education, mentorship, supporting, and developing the people that are in the respiratory care department. So that, for me, is a really important distinction, and it's allowed me to serve in a way that is focused on supporting the respiratory therapists in their own professional goals, their education, and their interactions with other professions and services within the hospital. I've also found that it's important to keep in mind that the medical director role is not a frontline provider. So I'm not the one that's actually delivering the care for the clinical guidelines that we develop and put into place in the hospital. That's distinct from my clinical responsibilities when I'm on service as an intensivist. So while my clinical service time as an intensivist gives me insight into how the respiratory therapists in the PICU perform, being medical director does not mean that I should or even could assume direct patient care responsibilities when I'm not the primary service attending. And what this means in practice is that my involvement in clinical guideline or protocol development has to assume that I'm not the one in charge of the direct patient care outlined by that clinical guideline. And it allows me to be very clear about emphasizing the development of consensus among all the involved stakeholders, thinking about effective implementation strategies, and then delegating ownership of the care process to the people who are actually delivering the care. The bulk of my time as medical director is spent understanding everyone's perspective, from respiratory therapy to bedside nurse to provider to pharmacy to unit and hospital leadership, and using that to help advocate for the respiratory therapists to gain knowledge, improve their communication skills, and enhance their ability to collaborate with the rest of the healthcare system.
Sounds like a lot of time spent having individual conversations with people and really understanding everyone's perspective.
Yes. Unfortunately, also a lot of time spent in big meetings.
That's right.
Yeah.
Many emails, yes. Alice and I, we hope that PEDSCRIT is a resource that current fellows will use, but also prospective critical care fellows. You're also the fellowship program director there in St. Louis. What would you like to brag about your program? You've already mentioned as a lung transplant center. What else would you like to highlight for us?
Sure. So I've been fellowship program director here at WashU since 2019 and had the privilege of stepping into the position when a lot of foundational work had been done by the program directors before me. And our vision really is to recruit pediatricians with the grit and drive to become future leaders in academic pediatric critical care and provide them with the opportunity to excel. And out of that vision then has become our approach to how to support our fellows. So from a clinical perspective, we're a high volume center. We have over 3,000 admissions to the PICU annually. We not only care for patients in our immediate region, but also across the Midwest, nationally and internationally. We offer all modalities of support, obviously including conventional and non-conventional ventilation, ECMO support, transplant of every organ except for small bowel and multivisceral. We are one of the highest volume lung transplant centers. We have a very, very large in-depth VAD program. So that's the clinical side. From then the non-clinical side, the way we approach our fellowship is to really help the fellows really think deeply about what their career goals are and what their interests are. And since most fellows are coming straight through without having had any break in their training from undergrad to med school to residency to fellowship, most of the applicants that come through really don't have a clearly defined research interest, and that's okay. That's typical. Because of that, we spend a lot of time asking our fellows to really think about what their clinical experience has been as they ramp up in their clinical activities, and how does that help inform their future career goals, whether it is in basic science, whether it's in clinical research, whether it's in administrative work, QI, medical education from either a research perspective and understanding better ways to provide educational opportunities in an adult learning framework, developing curricula, supporting interprofessional education. These, in my mind, all define what it means to be an academic intensivist. And sometimes people get through this and they realize that this is not really something they want to do, that their primary love and reason for being is direct delivery of bedside patient care. And that is totally fine because, as I said, most folks who are applying to peds critical care, they've never actually done anything but work in an academic center. So that's really all they know. Now, the nice thing or the amazing thing about peds critical care as a field is as you provide that direct patient care, you also are embedded into the unit and to the hospital system. And so every fellow, every practitioner of peds critical care really has to have an understanding of how the hospital system works and functions to support the ICU and the care that you're delivering. And how do you integrate with the patient, their family, the community, and how do you help ensure that as the patients transition from the ICU to the floor and then ultimately to home, that you as an intensivist have at least some understanding of what the pitfalls are when the patient is ready to leave the ICU. And so that's what we focus on in our fellowship from a non-clinical perspective, is really highlighting those points and the options that are available to someone who is interested in making this as a career.
That's fantastic. And I suspect Alice would say the same, but there are colleagues local here in Dallas who just really speak very highly of their training in St. Louis.
Oh, yes. Thanks. Great.
Yes.
That's awesome.
Got big fans everywhere.
Yeah. As we pivot to our conversation today on high-frequency percussive ventilation, any conflicts of interest to disclose?
Nope, I do not.
Wonderful. Alice, you want to give us a case?
Let's do it. So we're going to give you an 18-month girl admitted to the PICU for mixed hypoxemic and hypercarbic respiratory failure secondary to RSV. She was intubated shortly after presentation and continues to require high ventilator settings, paralysis, and frequent open bag suction to maintain ARDS net pH and PaO2 goals. the team is considering converting to high-frequency percussive ventilation, or the VDR. What is the VDR? What is high-frequency percussive ventilation?
So the VDR, the letters stand for Volume Diffusive Respirator. And because the VDR is the only commercially available ventilator that provides high-frequency percussive ventilation, people use the two synonymously. So throughout this presentation, I'll try to make a distinction when I'm talking about the mode of ventilation as opposed to the actual ventilator and the settings that are unique to the commercial product. But I may mess up and then just use the two together. So you just think of them as exactly the same thing. So the VDR is best described as a combination of pressure control ventilation and IPV. So VDR delivers high-frequency percussive ventilation that has an underlying rate delivered in a pressure control format as a flow decelerating pattern, and superimposed upon that are percussive breaths that are delivered similar to what you would see at the bedside if you are giving a patient intermittent IPV treatment. This is accomplished by a product, by a device, a mechanical device that the company has called the Phasotron. This sounds a little corny, but that's what they decided to call it.
It's very 1980s.
So the Phasotron sits between the ventilator circuit and the patient, right on the end of the endotracheal tube. And it's a mechanical device that has a spring-loaded sliding plate that moves back and forth based on Venturi flow. The open and closed positions of the sliding plate then generate a valved inspiratory and expiratory system that helps deliver or generate the high-frequency percussions. And each of those percussions delivers a small, subtidal volume-sized beat. It's important to keep in mind, though, that the VDR continues to rely on passive forces to allow the patient to exhale. And so the patient's underlying pulmonary mechanics, things like airway resistance, pulmonary system elastance, that's what allows the patient to exhale, same as every other ventilator in our armamentarium except for the oscillator. Another way to state this is that the oscillator is the only ventilator that has an active expiratory phase that helps facilitate escape of gas from the pulmonary system.
So my first impression, kind of reflecting on what you said, with the VDR or high frequency percussive ventilation, you have a ventilator that's set up similar to SIMV pressure control, but you have like this worked in IPV-like mechanism that's causing all these sub-physiologic tidal volume inspirations while relying on passive exhalation.
Exactly.
And what I know about high frequency percussive ventilation, it's used in cases like burn patients when there's a large secretion burden. And it almost seems like just by thinking about this little IPV along with pressure control gives you that advantage. So tell us more, if you don't mind, about what are the advantages for the VDR compared to conventional mechanical ventilation?
Sure. I see high-frequency percussive ventilation as having two primary advantages over conventional ventilation and other modes that are high-frequency, such as the oscillator or jet ventilation. The first is that it provides enhanced airway clearance that's created by the percussive forces of the high-frequency pulses. So thick or copious conducting airway secretions are a major contributor to your patient's respiratory failure, inhalational injury or burn injury, as Zach just mentioned, patients with cystic fibrosis and really thick secretions, or the bronchiolitic patient who has a copious volume of secretions. Then high-frequency percussive ventilation can be considered in much the same way that IPV might be deployed. The advantage is it's just continuous rather than intermittent. The second potential advantage of high-frequency percussive ventilation is enhanced CO2 clearance, or ventilation, with relatively lower average airway inspiratory pressures. And this occurs due to a combination of convective ventilation, which is generated by the tidal volumes that are delivered in the pressure control mode background, and the subphysiologic smaller tidal volumes that are delivered during the high-frequency percussive beats. So that combination of convective ventilation then augments the amount of bulk air movement that is getting moved in any given respiratory cycle. Also on top of that, then the VDR takes advantage of diffusive ventilation that's generated by the high-frequency component, similar to how gas exchange has been described to work in the oscillator. Lastly, there's increased washout of CO2 in the central conducting airways that's generated by the increased turbulence seen because of the way the high-frequency percussive ventilation mode works. There is one other patient scenario that I see the VDR as being extremely useful, and it's in the patient who requires inhaled nitric oxide, but also has really thick secretions, in which you might want to use IPV. So if you have a patient who's on nitric and you need to do IPV, every time you do IPV, you have to stop the nitric, which could cause major problems. On the VDR, you just run the nitric through the machine, and you get continuous delivery of both airway clearance and the pulmonary vasodilator.
Oh, excellent. This came up when we were talking to the team at Duke about high-frequency jet ventilation, and it's in one of their jet ventilation papers is where you've got sort of, if you picture a bronchiole or a central bronchi, you've got air coming down the middle and then sort of a continuous exhalation going around the outside. Is that something that you think about when it comes to percussive ventilation? Why it's so good at clearing these secretions?
I don't think so, because the physics of air movement related to the oscillator that creates a continuous pressure head, and with jet that generates a high velocity central flow that's continuous, that's a little different than the percussion beats. So the percussion beats, they are delivering a subphysiologic, but still measurable volume into the airway. It's not really a continuous pressure wave, nor is it a central continuous flow of high velocity gas. But that constant back and forth, and again, the exhalation of gas is really related to the passive forces that are involved in the patient's lung mechanics. What that creates is a relative net movement of gas and force that results in thick secretions being moved outwards or in the opposite direction that inhalation occurs. In some of the videos that the company uses to market their ventilator, it's actually pretty impressive how well that works. They have some figures that tend to over-exaggerate perhaps the mechanism of this. But in watching the ex vivo example and the model of what a conducting airway with thick junk in it does when the high-frequency percussive ventilator is added to it is quite remarkable.
You know, it seems like this high-frequency percussive ventilation strategy really solves a really difficult clinical situations when you have a child with refractory hypercapnia or hypoxemia who also has a severe secretion burden.
Right.
You think about these kids, managing them in conventional mechanical ventilation, maybe there's pressure control per se. You really want to also have some respiratory clearance, but to do that, you have to even disconnect them from, you know, their high PEEP settings. As I understand it, there would be no role for taking them off the VDR for additional respiratory clearance. Is that correct?
No.
And you would just do inline suctioning?
Correct. Yes, exactly.
One final follow-up question here is, these high-frequency percussive beats, would you expect the alveoli to actually see any increased peak pressure with that, or would this be something that's mitigated throughout the respiratory tree?
So certainly it is mitigated. The way that the ventilator measures pressures, it is measuring what the pressure would be at the airway. And with each decrement in size of the conducting cylinder-shaped tube, that pressure does diminish. In looking at explanted animal lungs that are hooked up to a VDR model, you can actually see the lung moving in time with the percussive beats. So those percussive waves are reaching the alveoli, but certainly not at the maximum pressures that the machine is measuring. There's unfortunately not really a good way to know exactly what that alveolar pressure is seeing above and beyond that driving pressure that defines the pressure control pattern of gas delivery. But it's a question that right now nobody's been able to answer, at least to my knowledge. But for sure, the alveoli are seeing fluctuations in pressure during those percussive beats.
Nice. We love an animal model YouTube visual. It's nothing better. John, we are going to get into how you set every single setting and why. But before we jump into that, what evidence is there for use of percussive ventilation or the VDR in pediatric critical care?
So the predominant clinical evidence for high-frequency percussive ventilation is in the form of case series for children. So there's no randomized trial. There are some attempts at providing some cohort comparisons. The earliest descriptions were really in patients who were on ECMO, for whom the VDR was used to try and promote lung re-recruitment and airway clearance. In these case series, use of the VDR was associated with shorter time on ECMO when it was included as part of a comprehensive approach to lung recruitment and secretion management. Most recently, though, in 2021, the group at CHOP published their experience with high-frequency percussive ventilation in a group of just under 200 patients. This report was published in Pediatric Pulmonology, and the authors describe in detail the ventilator settings prior to, during, and at the end of HFPV therapy, with accompanying blood gases, and then adjunct therapies such as inhaled nitric oxide, neuromuscular blockade, steroids, vasopressor score, and then other respiratory treatments. In this cohort, the reason for VDR use was predominantly hypercarbia and secretion clearance. So 32% of the patients, the reason for going on the VDR was hypercarbia, and 36% was secretion clearance. Prior to starting treatment with the VDR, just over 3/4 of the patients were supported either in pressure control or PRVC. 16% were on the oscillator, and interestingly, 4% were placed directly on the VDR as soon as they were intubated. Prior to starting HFPV, the median OI in the overall cohort was 16.5, with an observed mortality of 22%. So these are relatively sick patients. For people who are interested in reading the paper, it's in the February 2021 issue of Pediatric Pulmonology. The lead author is Andrew Butler. And, just to make it super simple, the PMID is 332-58557.
Heck yeah. This is a professor who drops a works cited in his notes sometimes. I love it.
So for me, when I read this paper, a few findings of this paper support what we've been describing so far. So first, the median age of this cohort was 3 years, with an interquartile range of 1.2 to 12 years. This is important because this is one of the things that we've observed in our own unit with use of the VDR, which is patients who are older than about 6 to 12 months who have an ET tube that is 3.5 or smaller. The resistance of the ET tube and the lower elastance of that patient's chest wall tends to make it harder for them to passively exhale. And so what we've seen is that these patients who have 3-5 ET tubes or smaller, they tend to get overdistended relatively quickly and then begin to have negative cardiopulmonary interactions. And the first thing we see is they start to get more and more tachycardic. And so whether that's an intentional thing that the group at CHOP was doing when they were selecting patients for the VDR, because certainly we see a lot of bronchiolytics who are intubated who have a 3-5 ET tube or smaller, or it just happens to be that's who they put it on. It supports what we've observed, which is it can be a little bit more challenging to manage the patient overall if they have a small ET tube or anything that is interfering with their ability to exhale. The second thing is that pH and PCO2 improved in all patients after being placed on the VDR within 2 hours, whether or not they were categorized as success from treatment with the VDR or a failure. And this supports the concept that HFPV enhances ventilation above what a conventional vent can provide with the typical pressures that we're using. And then third, what I've been talking about in terms of challenges when the patient has difficulty exhaling is that air leak was observed in 3% of VDR successes and 17% of VDR failures. And so you have to wonder whether or not that is a close association with a patient who has something about their respiratory mechanics that is interfering with exhalation and increasing the likelihood of development of air leak. Now, certainly it's confounded by the severity of the patient's respiratory failure, and I don't know off the top of my head what's the incidence of air leak in all patients who have severe ARDS who are on positive pressure ventilation. It's definitely less than 17%. And I think it's probably less than 3%, but I don't have that number off the top of my head.
My first thought is, oh no, are we giving people air leaks with the VDR?
So it's something that's important to be aware of and to follow, and it's why part of managing the VDR requires really, really close attention to what the pressures that are being measured are. The other thing about the relative advantages of the percussive ventilation is that you don't have to paralyze the patient, and you have less potential for adverse cardiopulmonary events and interactions, assuming there's no pneumothorax, because it still has that convective tidal volume rate from a higher pressure to a lower pressure. And you would improve cardiac output with improved preload, et cetera, when you drop down to the lower, quote unquote, PEEP that the VDR delivers. And in this paper, they saw that use of neuromuscular blockade and the vasopressor inotrope score did not change pre and post initiation of the VDR. So that's where the bulk of the data comes. And those who are interested should take a look. It's a decent paper.
Nice. Thank you. Congrats to that group at CHOP. That's awesome.
And maybe reflecting on your own practice, it seems like in this reference, most of the time the VDR was being used as rescue therapy or salvage therapy from a child with at least moderate to severe ARDS with a secretion burden. Very small number was actually primarily intubated and placed on that mode. How do you typically use it? Would you typically use it with the former where you're using it as a rescue? And maybe reflecting on that more, it seems like if there's a small ET tube, or perhaps even if there's like significant bronchospasm, the VDR might not work well for that population.
Sure. So those are two key points, Zach, that you've brought up. So if there is significant resistance to airflow, so lower airway tract obstruction, that you think is not related to secretions. So the bronchiolitic patient is going to have resistance to exhalation, both potentially because of airway edema and also because of secretions. And if you can deal with the secretions, then you've solved a big portion of the problem. But say the older patient who has some infectious process that also has underlying reactive airway disease, that's a patient to be super, super careful about, in general, managing their ventilator, but in particular, using high-frequency percussive ventilation as a mode of support. The other question you're asking, it really is back to like, when's the right time to use the VDR? And that's a challenging question to answer with a black and white response. So similar to the CHOP group, they very rarely go straight to the VDR after intubation. I have never initiated high-frequency percussive ventilation as the very first modality of vent support because I find that having them on the conventional ventilator really gives me a wealth of information about the underlying pulmonary mechanics. And then it allows us to understand whether or not we think that the patient would tolerate use of the VDR. So I'm more likely to initiate high-frequency percussive ventilation earlier in patients who have a known significant secretion burden that's leading to clinically important mucus plugging or atelectasis. And if I'm worried about significant bronchospasm, then I'll want that handled before trying the VDR. So say you have an asthmatic that happened to be in a house fire. So they have a combination of both bronchospasm and secretions. The secretions, for sure, are also exacerbating their underlying process. But if you can get the bronchospasm under control with bronchodilators, and you have reasonable control of that, there isn't necessarily an absolute contraindication to then try the VDR to promote airway clearance. But you have to be on top of that bronchospasm. The other area in which the VDR may not necessarily be as effective as other conventional or non-conventional modes is in the patient whose primary gas exchange defect is oxygenation. For that patient, then, the typical conventional approach with high PEEP, low driving pressure, or use of the oscillator, or just put them on ECMO. I wouldn't really think of using the VDR as a quote-unquote salvage approach or a last-ditch effort to prevent ECMO. I would use it in a patient who is starting to demonstrate that airway secretion control is a problem, who is having issues with hypercarbia that are becoming challenging to manage, either because in trying to limit driving pressures to 15 or less, the rate needs to be high enough that you're starting to approach an inverse I to E, and then every now and then it seems that a secretion mucus plug gets in the way, and they have an acute decompensation. But that's a patient I would try the VDR sooner rather than later.
And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening. What should the Pete's Crit listeners keep in mind about percussive ventilation?
So unfortunately, as of October 31st of this year, the company that makes the VDR isn't going to make it anymore. So they are pulling out of the US market. They'll continue to service and support active VDR devices for up to 10 years. And then they have this phrase in their announcement, as long as components are available and as long as the cost of repair is reasonable.
Oh, no.
So whatever that means.